further analyze the active genes and look at patterns that allow you to recognize different etiological origin, different classes of outcome of disease, and it may help you to define prognosis and treatment response. But also, for instance, different etiology, meaning that breast cancers arising in patients that have a BRCA1 mutation look different than tumors that arise in patients that don't carry such a germline mutation. And so you can recognize patterns to give insight in the tumors that are developing. So one of the first microarray analyses, and here, although it's not a beautiful Andy Warhol picture, but you should think of it in the same way, because here those red and green spots, which represent red active gene, green is non-active genes, are already sorted in a way that it allows you to recognize a pattern. And those patterns are sorted out in such a way that here at the top of the slide you can see that there are branches of tumors that are very similar. So you can also see that the pattern, if you go from top to bottom, is very similar if you follow these colored branches on the top. And so that has been published by Peru and Surrey in 2000 and 2002, that based on the recognition of patterns, breast cancer is actually not one disease, but that you can sort it out in this particular analysis in 5 diseases. And this result actually still stands. There are now maybe 5 or 6 classes, depending how you analyze the data in which tumors you put into your mixture. In large part, it's 5 main types, but there are 2 that also exist. And so what they also observed, that these 5 different types of breast cancer, so they are recognized as having a particular gene pattern, that if you look at outcome of disease, that these have different outcome of disease if you follow patients that either have a luminal A, as it's called, tumor, or here in red, a basal tumor. And so that gives you also, besides that the gene activity pattern is different, this also tells you that there are different outcomes of disease seen for these patients. Although these patients were also treated by systemic therapy, that gave us insight that it really makes a difference. So if you now want to look for prognosis of disease, what one wants to do is to take a little piece of a tumor, isolate the active genes, which is the DNA translated in RNA, put a fluorescent label on those and analyze them either by a technique called RT-PCR or, for instance, by microarrays. Either one can work. Then you have already, you want to determine a pattern in this that actually resembles tumors in patients that have a high likelihood to develop metastases or a low likelihood, and therefore the gene activity pattern is called poor prognosis or good prognosis signature. And so this is a whole series of gene expression signatures that were all developed. Well, most of them were developed, others turned out to be to the prognostic value. So we worked on 70 genes in our so-called Amsterdam or NKI 70 gene signature. There's the recurrence score, there's the Hox-IL ratio, and then there are several others developed as listed here. So in large part they identify overlapping tumors in patients of having a high risk or low risk of recurrence, although it's not completely concordant. Something to further sort out. So the question, so now I'll tell you also more in depth how we developed our 70 gene profile, and what it actually took us to really make it into a diagnostic test for patients. So the question was, after surgery at time point 0, which breast cancers return and give a high likelihood the patient will die of their disease, and who are the patients that actually will not get a recurrence in 10 years, which is currently used as an estimate to determine who needs and who does not need systemic chemotherapy. So also based on clinical pathological factors like age, estrogen receptor present in the tumor, the gray rate, which defines number of dividing cells, tumor diameter, number of positive nodes. There is an online system called Adjuvant Online, developed by Peter Rebden, that many physicians use to get some insight in what is the likelihood that this particular patient, 50 years, these characteristics, what is the 10-year risk of dying of the disease for this particular patient. And so that's seen here, this particular patient with no additional therapy besides mastectomy or lumpectomy followed by local radiotherapy. 72% is alive in 10 years, 24% will die of her cancer, and 4% will die of other causes. And based on the integration, so this is actually based on a large database of SEER data of patients who were treated in the past in the US and of whom follow-up is known. So also based on meta-analysis of many clinical trials using hormonal therapy, in this case tamoxifen or chemotherapy, one can estimate what is actually the benefit of giving this particular patient or a group that has those characteristics who benefit from hormonal therapy, chemotherapy, or the combination. And so this is frequently being used and gives you already some insights based on the integration of all these factors. But so he also once showed that if you take one of the common diagnostics of breast cancer, which is a tumor smaller than 2 centimeters, no positive nodes, ER positive grade 2, then you need to treat 100 women with chemotherapy for the benefit of 1. And there are many more, examples here, that will suffer from side effects. So there is a trade-off at one point, how far do you want to go? And it's also very patient preference specific. Maybe some patients do want chemotherapy even if the chance of getting a benefit is only 1 out of 100, whereas other women may decide that only when it is 10 out of 100 they would suffer the potential side effects. And there are many more details about it. Also, Martine Picard, it was a medical oncologist from Brussels in Belgium. She some years ago undertook with a series of hypothetical patients. She asked 40 experts worldwide what they actually would do at that point in time. So it was presented at ESCO in 2003, and you can read the characteristics of a particular patient here. Those 40 experts, which are really key opinion leaders, came back that half of them would give no systemic therapy, 25% would CMF, chemotherapy, 15% AC, 4 would only give hormonal therapy, and 8 would do something else. So you can see that even if there are guidelines, there can be many reasons to make the choice one way or the other. And it's also interesting, I do know in Europe that, for instance, giving chemotherapy in the northern part of Europe is much more conservative than in the southern part. So let's say in Italy and Spain, almost 80 or 90% of women would get chemotherapy, whereas in the Netherlands it has for years been very conservative in giving chemotherapy in those same situations. Only in 20% women will get chemotherapy. So it's also cultural based, which is understandable. So there are many things that play, and of course we all would like to do the best that we can. So we set out to see whether a microarray could help us to identify patients that have a high or low risk for distant metastasis. And you can see here that there are 2 different patterns above and below the yellow line that are different in gene activity, as seen by red active genes and green in a certain constitution here and a different one below. And here you can see that those women who were treated in the past and we knew what happened to them later, which ones of them developed a metastasis. And this then led to the identification that this pattern would resemble a good signature and this pattern would resemble a poor signature, where in this part there's only a very low risk of metastasis. And I think just to point out to you that we put this threshold here allowing some patients to develop a metastasis